All right, so picture this. You're on call in the ED,
Oh, yeah.
and a woman comes in with vaginal bleeding.
Happens all the time.
Super common, right?
Absolutely.
It can be anything.
It can be a lot of
Right.
things.
So many potential causes.
And as a general practitioner, you really got to be on your toes.
That's what this deep dive is all about.
Okay.
We're going to give you a system
Right.
for evaluating and managing
Okay.
adult patients with vaginal bleeding in the ED.
I like it.
We've got guidelines, research articles, all that good stuff.
Sounds good.
So
Good.
our sources all emphasize, a
Mm-hmm.
really good history is
Right.
the foundation here.
Yeah, for sure.
But before we even get to the specifics,
Okay.
what are some of the bigger picture things we have to think about?
Well, I mean, first and foremost,
Yeah.
is this patient stable?
Okay, so right away,
Okay. Stability first.
hemodynamically stable.
Okay. Got it.
Because if they're not,
Yeah.
that changes the whole game.
Then we need to know, are they pregnant?
Okay.
Could they be pregnant?
So pregnancy status.
And then if they're not,
Yeah.
age becomes a big factor.
Okay.
And figuring out what are the most likely causes.
Got it. So it's like this triage system, almost
Exactly.
stability,
Yep.
pregnancy status,
Uh-huh.
and then age kind of guides our thinking.
You got it.
Okay, that makes sense.
Mm-hmm.
So then once we have those basics down,
Right.
we really need to get a good detailed history.
For sure.
And our sources have this really helpful table
Oh, great.
that breaks down all the key questions.
Okay, let's hear it.
So let's dig into that.
All right.
What are some of the must-ask questions about the bleeding itself?
We want to know, when did it start?
Okay.
How long has it been going on?
Yeah.
How much blood are we talking about?
Yeah.
Is it heavier than their usual period or lighter?
Okay.
Are they soaking through pads or tampons really quickly?
Those are good, real
Yeah.
practical questions.
Real world stuff. That tells us a lot.
Okay, so that paints a picture of what's happening right now.
Right.
What about their past?
Yeah.
What do we need to know about their history?
You want to know all about their menstrual history.
Okay.
When was their last period? How regular are their cycles?
Mhm.
How heavy is their usual flow?
Okay.
And if they've already gone through menopause, when was that?
Right, so we can compare it to
Yeah.
what's normal for them.
Yep. Yeah.
And I imagine we also need to ask about
Yeah,
potential causes beyond just
Okay.
normal menstruation.
absolutely.
So what are we looking for there?
So you want to know, have they had any trauma
Okay.
to the pelvic area?
Mm-hmm.
Have they ever been diagnosed with any bleeding disorders?
Okay.
Any other health conditions that could be playing a role?
Got it.
And of course, we need a full medication history,
Okay.
including anything over the counter or any supplements they're taking.
So we've got the history.
What?
What about the physical exam? Are there specific things we should be looking for?
Definitely.
You're cute.
Again, we're assessing their hemodynamic status.
Okay.
Vital signs are important, but
Mhm.
remember,
Yeah.
especially in young, healthy patients,
Okay.
they can compensate for a lot of blood loss
Oh, wow.
before their vital signs really tank.
So that's a good reminder to not just be like, oh, their vitals are fine. Oh,
Exactly. Don't
okay.
be fooled.
Okay.
So we need to really look for signs of shock,
Okay.
like pale skin, rapid heart rate, altered mental status,
Got it.
all those things.
So then the pelvic exam itself,
Yeah,
are there any special considerations
absolutely.
since we're in the ED?
One of our sources really emphasized,
Okay.
if a woman is pregnant
Yeah.
and presenting with bleeding after 20 weeks,
Okay.
we cannot do a manual pelvic exam
Okay.
until we've ruled out placenta previa with an ultrasound.
Wow, that's a
Yeah.
really important point.
It's huge.
Why is that so critical?
Because if the placenta is covering the cervix,
Yeah.
a manual exam could cause catastrophic bleeding.
Oh, wow.
It's a situation where we need to be extra cautious.
Okay, so ultrasound becomes a top priority
Absolutely.
in those cases.
First thing,
What other ancillary studies are we thinking about?
well, for any woman of childbearing age,
Yeah.
a pregnancy test is a must.
Okay.
And if it's positive,
Mm-hmm.
then that pelvic ultrasound becomes even more important.
Okay.
Not just to rule out previa,
Yeah.
but to determine,
Okay.
where is the pregnancy? Is
Right.
it viable? All of that.
Makes sense.
Mm-hmm.
Now let's say
Okay.
we're dealing with a pregnancy under 20 weeks
All right.
and things are
Right.
pointing to a
Yeah.
potential ectopic pregnancy.
Okay.
What are our next steps?
First, we need to confirm the pregnancy
Okay.
with a quantitative serum HCG,
Okay. And why is that?
because a urine test might not be sensitive enough
Oh, yeah.
to pick up an early ectopic.
Got it.
And that transvaginal ultrasound is essential
Okay.
to try and locate the pregnancy.
And what if the ultrasound doesn't give us a clear answer?
Then we have what's called a pregnancy of unknown location,
Pregnancy of unknown location.
which doesn't necessarily mean something is wrong,
Okay.
but it does mean we need to keep a close eye on things.
Got it.
We'll probably need to repeat the HCG level in 48 hours
Okay.
and maybe do another ultrasound later to see if anything has changed.
So vigilance is key
Absolutely.
in those cases.
Yep.
Okay. So now shifting gears a bit,
Right.
let's talk about some of the potentially life-threatening causes
Okay.
of vaginal bleeding,
Sure.
especially in early pregnancy,
Mhm.
under 20 weeks.
Yeah.
What are the big ones we need to have on our radar?
Well, ectopic pregnancy is definitely at the top of the list.
Okay.
It's a true emergency,
Yeah.
and we need to act fast if we suspect it.
Okay.
Another one is retained products of conception,
Okay.
which can happen after a miscarriage or an abortion.
And both of those can cause significant bleeding
Absolutely.
and other complications
Yes, sir.
if not addressed promptly.
Exactly.
And while it's thankfully uncommon,
Right.
we also can't forget about
Yeah.
potential complications after a pregnancy termination.
Mm-hmm.
Things like bleeding from lacerations,
Yeah.
uterine perforation infection.
All those.
Those all require immediate attention.
Absolutely.
So it sounds like early pregnancy comes with a whole set of unique challenges
It does.
when it comes to vaginal bleeding.
For sure.
Okay, so we've covered some of the basics,
Mm-hmm.
touched on a few life-threatening causes
Right.
in early pregnancy.
Yep.
What about pregnancies over 20 weeks?
Okay.
What are the major red flags
All right.
we need to be watching for
Yeah.
in that stage?
So when we're talking about pregnancies over 20 weeks,
Yeah.
the stakes are even higher.
Okay.
Two conditions that immediately come to mind
Mm-hmm.
are placental abruption and placenta previa.
Okay, those are both ones we hear about a lot.
Yeah, they're big ones.
Can you break down the key differences between them
Absolutely.
in terms of like
Yep.
how they present and how we approach them in the ED?
So with placental abruption,
Okay.
the placenta detaches from the uterine wall prematurely,
Okay.
which can be life-threatening for both the mother and the baby.
Wow.
The classic presentation
Yeah.
is sudden onset severe abdominal pain,
Okay.
often described as knife-like or tearing.
So pain is a big red flag
Big time.
for abruption.
Yeah.
What about the bleeding itself?
That's where things can get tricky.
Okay.
The amount of external bleeding
Yeah.
doesn't always correlate with the severity of the abruption.
Oh, interesting.
You could have a patient with a massive concealed abruption
Yeah.
and very little visible blood,
Wow.
or a patient with a smaller abruption and a lot of bleeding.
So we can't just rely on
Right.
the amount of blood we see.
It's not a reliable indicator.
What about ultrasound? Is that helpful?
Unfortunately, ultrasound isn't always reliable for detecting abruption either.
Really?
It can miss up to 50% of cases.
Wow, that's a
Yeah,
pretty significant number.
it is.
So how do we approach a patient
Mhm.
where we're highly suspicious of
Uh,
abruption,
yeah.
even if the ultrasound doesn't show it?
In those cases, clinical judgment is paramount.
Okay.
If the mom is having painful contractions,
Yeah.
the baby is showing signs of distress on the fetal monitor,
Mm-hmm.
and mom's vital signs are unstable,
Okay.
we need to act fast.
Got it.
Even if the ultrasound isn't definitive,
Okay.
immediate obstetric consultation is a must.
Okay, so a high index of suspicion
Absolutely.
is key
Yeah,
for abruption.
for sure.
What about placenta previa?
All right.
How does that typically present?
Placenta previa is when the placenta partially or completely covers the cervix.
Okay.
Unlike abruption,
Yeah.
it typically presents with painless bleeding,
Oh, okay.
often bright red in color.
So painless bleeding.
Yep.
That's a good distinguishing feature.
Big one.
Is ultrasound helpful for diagnosing previa?
Yes, ultrasound is very reliable for diagnosing placenta previa.
Mhm.
It allows us to visualize the placenta's location
Got it.
and see if it's encroaching on the cervix.
Okay, that makes sense.
Mm-hmm.
So for both abruption and previa,
Right.
immediate OB consult
Absolutely.
is the way to go.
Yeah. Get them involved right away.
What other serious conditions do we need to be thinking about
Okay.
in pregnancies over 20 weeks?
One that's particularly concerning,
Okay.
especially in women who've had a previous C-section,
Mm-hmm.
is uterine rupture.
That sounds terrifying.
It can be.
How does that usually present?
It can vary,
Okay.
but classic signs are sudden, intense abdominal pain,
Okay.
often different from labor pains,
Hmm.
along with abnormal fetal heart rate patterns.
Got it.
Vaginal bleeding might be present,
Okay.
but it's not always a prominent feature.
And what do we do if we suspect a uterine rupture?
It's an absolute surgical emergency.
Wow.
We need to get the OB team in there immediately
Okay.
to deliver the baby and repair the rupture.
It really highlights how critical it is to have a good grasp
Yeah,
of these high-risk conditions
absolutely.
when we're managing pregnant patients
Mm-hmm.
with vaginal bleeding.
It really does.
And it underscores the importance of that initial assessment.
Right.
Stability pregnancy status,
Yep,
gestational age.
exactly.
It helps us quickly categorize
For sure.
the patient
Uh-huh.
and determine the urgency
Anyway.
of the situation.
Yeah,
Okay, so we've covered the high-stakes scenarios.
right.
Let's shift gears
Right.
and talk about some of the non-life-threatening causes
Okay.
of vaginal bleeding we might encounter,
Sure.
starting with those related to pregnancy.
Of course.
Yeah.
One common cause, particularly for those in labor, is bloody show.
Bloody show.
This is essentially a vaginal discharge
Right.
that's tinged with blood and mucus, indicating the passage of the mucus plug that seals the cervix during pregnancy.
Got it.
It's usually a normal part of labor progression.
Right, so we'd expect that
Yeah,
as labor gets going.
exactly.
What about earlier in pregnancy?
Unfortunately, spontaneous abortion or miscarriage, as it's more commonly known,
Mhm.
is a fairly frequent occurrence.
Okay.
Women experiencing a miscarriage
Yeah.
will often report vaginal bleeding and cramping.
And what's our approach
Okay.
in suspected miscarriage?
An ultrasound is crucial
Okay.
for confirming the diagnosis
Mhm.
and making sure it's not an ectopic pregnancy.
Got it.
Depending on the gestational age,
Yeah.
the patient's hemodynamic stability,
Uh-huh.
and their wishes,
Mhm.
management can range from expectant management,
Okay.
where we allow the miscarriage to happen naturally,
Okay.
to surgical intervention like a dilation and curettage.
Got it.
This is definitely a situation where shared decision-making is key.
It sounds like there's a lot of nuance involved
There is.
in managing miscarriages.
Yeah, for sure.
What about causes of bleeding that aren't related to pregnancy?
There are a ton of possibilities.
Okay.
And again, the patient's age is a big clue.
Right.
Let's start with those who haven't gone through menarche yet.
Okay, so premenarchal patients.
Yep.
What sorts of things are we looking for
Right.
in this age group?
The differential diagnosis is pretty different here.
Okay.
We're thinking about things like vulvovaginitis,
Vulvovaginitis.
which is inflammation of the vulva and vagina,
Okay.
often caused by infections.
Okay.
Trauma to the area is another possibility,
Mhm.
whether accidental or unfortunately due to abuse.
Right.
Foreign bodies in the vagina are another consideration, especially in younger children.
Yeah.
And we also need to be aware of conditions like urethral prolapse,
The urethral prolapse.
where a portion of the urethra protrudes outside the vaginal opening.
Okay.
It can be alarming to see,
Yeah, I imagine.
but it's usually not serious.
So a careful and sensitive approach is especially important in
Absolutely.
these young patients.
It is.
What about premenopausal women? What are the common culprits we see
Okay.
in this group?
In premenopausal women,
Mm-hmm.
the most frequent causes are usually related to hormonal fluctuations
Okay.
or structural abnormalities of the reproductive system.
Got it.
Things like ovulatory dysfunction,
Ovulatory dysfunction.
where the ovaries aren't releasing eggs regularly,
Okay.
can lead to irregular bleeding.
Got it.
Fibroids, which are benign growths in the uterus,
Mm-hmm.
are another common cause,
Okay.
as are polyps, which are
Oh.
small growths in the lining of the uterus.
Right. Those are all things we see
Yep.
pretty regularly in primary care.
Pretty common.
Anything else we need to keep on our radar?
We also need to be thinking about ruptured ovarian cysts
Okay.
and ovarian torsion,
Okay.
although those usually present with pain as the primary symptom.
Got it.
And we can't forget about pelvic inflammatory disease, or PID, which is an infection of the reproductive organs.
So even in premenopausal women, there's a
Yeah,
pretty wide range of possibilities.
for sure.
Anything specific we should be looking for in this age group to help narrow things down?
One thing that's really important to remember
Okay.
is that even if a woman says she's not pregnant,
Yeah.
we can't rule out an ectopic pregnancy
Okay.
without a negative pregnancy test,
Got it.
especially if they're having significant bleeding.
Okay.
And regardless of their contraceptive method, we need to have a high index of suspicion for ectopic pregnancy
Got it.
in any woman of reproductive age with abdominal pain and vaginal bleeding.
Okay, that's a really good point.
Yeah, it's easy to get tunnel vision.
So never assume anything
Right.
without solid evidence.
Exactly.
What about postmenopausal women?
Right.
What are our main concerns
Okay.
in this group?
In postmenopausal women, endometrial cancer becomes a top concern. Any bleeding after menopause is considered abnormal
Got it.
and needs to be investigated.
What are some of the risk factors we should be aware of
Okay.
for endometrial cancer?
Obesity,
Okay.
a family history of cancer,
Mm-hmm.
and a history of irregular periods or polycystic ovary syndrome
Okay.
all increase the risk.
Got it.
Additionally,
Yeah.
women who have never been pregnant
Right.
or who started their periods very early or went through menopause late are also at higher risk.
So if we have a postmenopausal woman with any bleeding, it sounds like a prompt referral to a
Absolutely.
gynecologist is essential.
Get them in there. ASC.
Okay, so we've talked about a lot of different causes,
We have.
both benign and serious, but I'm curious,
Yeah.
what about those cases
No.
where the bleeding just doesn't seem to stop,
Right.
even with treatment?
And those tricky ones.
What are some less common causes we might be missing?
That's a great question.
Yeah.
One condition that our sources mentioned that's important to consider,
Mhm.
especially in those cases of refractory bleeding,
Right.
is a uterine arteriovenous malformation, or AVM.
AVM.
Yeah.
That's not one we hear about every day.
It's not super common.
Can you tell us a bit more about that?
Sure.
What is that?
An AVM is basically an abnormal tangle of blood vessels in the uterus,
Okay.
where arteries and veins connect directly without the usual capillary network.
Interesting.
These abnormal connections
Yeah.
can cause heavy, unpredictable bleeding.
Okay.
That can be really tough to manage.
So how do we go about diagnosing an AVM?
Pelvic ultrasound, specifically with Doppler imaging,
Okay.
is usually the key to diagnosis.
Got it.
It allows us to see the characteristic turbulent blood flow
Okay.
within the AVM.
It sounds like AVMs can be a real diagnostic challenge.
It can be tough.
What about treatment?
Yeah.
Are those difficult to manage as well?
Treatment can be complex.
Okay.
Sometimes hormonal therapy can help control the bleeding, but in more severe cases,
Yeah.
embolization, where we block off the abnormal blood vessels,
Okay.
might be necessary.
Got it.
This is definitely a situation where we'd want to involve a
Yeah.
gynecologist or interventional radiologist.
Okay, so AVMs are something to keep in mind,
Oh, sure.
especially when we're dealing with
Yep.
persistent bleeding that's not responding
Right.
to our usual treatments.
Exactly.
It's a reminder that
Mm-hmm.
even though the common things are common,
Right.
we can't get tunnel vision
Absolutely.
and miss those less frequent,
Uh-huh.
but potentially serious diagnoses.
Very true.
All right, so we've covered a ton of ground here,
We have.
from basic anatomy and physiology
Mm-hmm.
to life-threatening emergencies
Yep.
and rare conditions.
It's a lot.
I feel like we barely scratched the surface.
Yeah, just the tip of the iceberg.
But it's a good reminder of just how much goes into
Right.
evaluating and managing
Absolutely.
vaginal bleeding.
It's complex.
Speaking of navigating effectively,
Okay.
let's say we've stabilized our patient,
All right.
figured out their pregnancy status,
Mm-hmm.
and considered the most likely diagnoses based on their age.
Okay.
What are our next steps
up?
in
It's
terms
you.
of management?
Well, that's where the real detective work comes in.
Okay.
We need to consider what additional testing is necessary
Right.
to pinpoint the diagnosis and guide our treatment plan.
Got it.
A complete blood count is a good starting point
Okay.
to assess for anemia,
Mm-hmm.
especially if the bleeding has been heavy.
And for women with heavy bleeding,
Yeah,
I imagine we'd also want to check their coagulation factors
absolutely.
to rule out any underlying bleeding disorders.
Exactly.
And if anemia is significant,
Right.
iron supplementation.
Usually necessary. If they
Alright.
need a transfusion,
Mm-hmm.
we really need to figure out the underlying cause of their bleeding
Yeah.
to make sure it's addressed appropriately.
And of course, close follow-up with a gynecologist
Because-
is crucial in many of these cases,
Absolutely.
especially if the
Yeah.
cause of bleeding is unclear
Right.
or requires specialized management.
Exactly.
Now, let's say we're dealing with
Okay.
a premenopausal woman with irregular bleeding,
Mm.
and our initial evaluation
Mhm.
hasn't revealed any obvious cause.
Okay.
What are some other diagnostic tools we
Mm.
can consider?
I'm thinking things like pelvic ultrasound
Pelvic ultrasound.
to look for structural abnormalities like fibroids or polyps.
Okay.
And maybe an endometrial biopsy.
Endometrial biopsy.
If we're concerned about endometrial cancer.
Okay, those are all
Yeah.
excellent considerations.
They are.
Transvaginal ultrasound is particularly useful.
Yes.
Because it provides a clear view of the uterus and ovaries.
Exactly.
And an endometrial biopsy is considered the gold standard.
It is.
For diagnosing endometrial cancer.
For sure.
What about hormonal therapy?
Okay.
Is that something we consider in the ED setting?
Hormonal therapy like oral contraceptives or progestins can be helpful for regulating menstrual cycles and reducing bleeding.
Got it.
But before starting any hormonal therapy, we need to be absolutely certain that we've ruled out pregnancy and endometrial cancer.
That makes sense.
Yeah, we wouldn't want to mask any underlying serious conditions.
Right.
And it's also important to remember that hormonal therapy isn't a quick fix.
Okay.
It often takes several cycles to see the full effects.
So education and realistic expectations are key.
Absolutely.
When we're talking about hormonal therapy.
It's a conversation.
With our patients.
Yep.
Okay, so we've talked about a lot of different management options.
Yeah, depending on the suspected cause.
Depending on the suspected cause.
Of the bleeding.
Of the bleeding.
Right.
What are some general principles we should keep in mind when managing any patient with vaginal bleeding in the ED?
Pain management is always important.
Okay.
We want to make our patients as comfortable as possible while we're working to figure out what's going on.
And I imagine emotional support
absolutely.
is crucial as well.
Huge.
A lot of these conditions can be quite frightening for patients.
They can be scary.
You're absolutely right.
Yeah.
It's essential to approach our patients with empathy and understanding.
For sure.
Vaginal bleeding can be a very personal and emotionally charged issue.
It can.
And taking the time to listen to their concerns and address their fears can go a long way in providing good care.
Absolutely.
Okay, so pain management, emotional support, and clear communication are all key.
They are.
Anything else?
Documentation is absolutely essential.
Documentation?
We need to thoroughly document the patient's history, physical exam findings, results of any tests,
Got it.
and our clinical reasoning for the chosen management plan.
Right. Good documentation not only helps ensure continuity of care, but also protects us legally.
Absolutely.
And it's especially important in these cases where the diagnosis might not be immediately clear. And we might need to refer the patient for further evaluation and management.
Exactly.
All right, so we've covered a lot of ground in this deep dive. We've talked about everything from the basics of the menstrual cycle to the complexities of managing life.
Yep. Threatening bleeding and pregnancy.
Yeah.
But before we wrap up, I wanted to circle back to something you mentioned earlier.
Okay.
About ectopic pregnancy.
Ectopic pregnancy.
It seems like that's a condition we really need to be on high alert for.
Yeah, for sure.
Especially in the ED setting.
Absolutely.
You're absolutely right.
Yeah.
Ectopic pregnancy is a true masquerader.
Okay.
It can mimic so many other conditions.
Right.
And the consequences of missing it can be devastating.
So what are some of the key things we need to keep in mind to avoid missing an ectopic pregnancy?
First and foremost,
yeah,
we need to have a high index of suspicion.
Okay. High index of suspicion.
Any woman of reproductive age presenting with abdominal pain or vaginal bleeding needs to be evaluated for ectopic pregnancy.
Got it.
Even if she says she's not pregnant or is using contraception.
So we can't just take their word for it.
Nope.
We gotta
be suspicious.
Be suspicious.
Yeah.
Okay.
And what are the classic symptoms of ectopic pregnancy?
Yeah, what are we looking for?
The classic triad is abdominal pain, vaginal bleeding, and amenorrhea.
Got it. So all three of those together.
Right.
Yeah.
But remember, not every patient will present with all three symptoms.
Right.
And sometimes the bleeding can be very light or even absent.
So we can't just rely on those classic signs.
Nope. They don't always show up.
What about risk factors?
Okay.
Are there any that should make us extra suspicious?
Absolutely.
Yeah.
A history of pelvic inflammatory disease.
Okay. PID.
Previous ectopic pregnancy. Tubal ligation.
Okay.
Or IUD.
Got it.
All increase the risk.
So if we have a patient with those risk factors and any concerning symptoms, what are our next steps?
A urine pregnancy test is a good starting point.
Okay. Urine pregnancy test.
And we can't rely on that alone.
Okay.
We need a quantitative serum HCG.
Quantitative serum HCG.
To accurately assess the level of pregnancy hormone.
Okay.
And a transvaginal ultrasound is essential.
Okay. Transvaginal ultrasound.
To try to visualize the pregnancy and determine its location.
And what if the ultrasound doesn't show a definitive intrauterine pregnancy?
Then we have that pregnancy of unknown location situation.
Pregnancy of unknown location.
And in that case, we need to repeat the HCG levels.
Okay, repeat HCG.
And likely repeat the ultrasound to monitor the situation closely.
So close monitoring is key.
Absolutely.
When we're dealing with a potential ectopic pregnancy.
You got it.
Any other pearls of wisdom
about
managing these cases in the ED?
I think the most important thing is to consult with a gynecologist early on.
Okay. Early gynecology consult.
They can help guide management decisions, whether that's expectant management, medication, or surgery.
Got it. That makes sense. It's better to get expert input sooner rather than later.
Absolutely.
In these situations.
Early intervention is key
to
preventing potentially life-threatening complications.
All right, so we've covered a lot of ground on an ectopic pregnancy.
Yeah, that's a big one.
But I want to touch on one more important aspect of managing vaginal bleeding in the ED.
All right.
Pain management.
You're right.
Yeah.
Pain management is essential.
Okay.
These patients can be in significant discomfort.
And providing adequate pain relief can make a huge difference in their overall experience.
Absolutely.
So.
Yeah, what are some of the go-to options
for
pain management in these cases?
Non-steroidal anti-inflammatory drugs.
Okay. NSAIDs.
Like ibuprofen or naproxen are usually a good first-line option for mild to moderate pain.
And for more severe pain.
Opioids might be necessary.
Okay.
But we want to use them cautiously.
Right.
Especially in pregnant patients.
Of course, we always want to weigh the risks and benefits.
Absolutely.
Carefully when considering opioids.
Right.
Especially during pregnancy.
For sure.
Are there any non-medication options for pain relief we can offer?
Things like heat therapy or positioning can sometimes provide comfort.
Got it.
And simply taking the time to listen to the patient's concerns and validate their pain can also go a long way.
Right, just that human connection.
Exactly.
Can make a big difference.
It can. Okay, so a multimodal approach to pain management, considering both medication and medication options, is key.
Absolutely.
We want to tailor our approach to each individual patient's needs.
For sure.
And preferences.
All
right, so we've covered a lot of ground
we have
in this deep dive.
It's a lot of info.
Into vaginal bleeding.
Yeah.
We've discussed the importance of a systematic approach.
Right.
The key considerations based on pregnancy status and age and the wide range of potential causes.
Yep. From the benign to the life-threatening.
But I'm wondering, with all the information we've covered, what's the one key takeaway you'd want our listeners to remember?
That's a great question.
Yeah.
I think the most important thing to remember is that vaginal bleeding, while a common presentation, can be a sign of a wide range of conditions, some of which are life-threatening.
Okay.
So it's crucial to have a high index of suspicion.
High index of suspicion.
Ask the right questions, perform a thorough exam, and utilize diagnostic tests judiciously.
Got it.
To ensure we're not missing anything serious.
So vigilance is key.
Absolutely.
In knowing when to call for backup.
For sure. Well, if you're ever unsure about a case,
Yeah.
Don't hesitate to consult with a gynecologist or another specialist.
Okay, get that consult.
It's always better to err on the side of caution.
Right.
When it comes to vaginal bleeding.
This has been such a valuable deep dive.
It has been.
I feel like I've learned a ton.
Glad to hear it.
About the complexities of managing vaginal bleeding in the ED.
It's a lot to take in.
It is.
But hopefully this has been helpful.
It has.
For your practice.
And now we're going to turn the tables on you a bit.
Right.
Considering everything we've discussed, what do you think is the most important skill for a general practitioner to have when faced with a patient with vaginal bleeding in the ED?
That's a thought-provoking question.
It is a big one.
I'd say the most important skill is the ability to quickly and accurately assess the patient's stability, determine the urgency of the situation, and initiate appropriate management.
Got it.
While simultaneously considering the vast range of potential causes.
So it's a combination of clinical knowledge, critical thinking, and the ability to act decisively under pressure.
Exactly.
And it's about knowing when to involve other specialists.
Absolutely.
And not being afraid to ask for help.
Couldn't agree more.
Vaginal bleeding can be a complex and challenging presentation.
It can.
But with a systematic approach and a good understanding of the key principles, we can provide excellent care to our patients.
Absolutely, we can.
Yeah, it really is like a puzzle sometimes.
It is. It's putting all the pieces together.
Right.
And that's what I think makes it so interesting.
But also so challenging.
Absolutely.
You really have to use your brain.
Right. There's no, brick book answer.
No recipes here.
For every case.
Nope.
Speaking of, frameworks and stuff.
Okay.
One of the sources had this fascinating algorithm.
Oh, cool.
For managing abnormal uterine bleeding.
Okay.
In non-pregnant women.
Right.
What are your thoughts on using algorithms like this in practice?
I think algorithms can be really helpful.
Okay.
Especially in a busy ED.
Yeah, where you have to make decisions fast.
Exactly. When you've got patients lining up,
right,
they can help us stay organized.
Okay.
Make sure we're considering all the important factors.
Got it.
But we also need to remember that they're just guidelines.
Right. They're not set in stone.
Exactly.
Yeah.
We always need to individualize our approach.
Right. It's about using the algorithm as a framework.
Yeah. A roadmap.
Not a rigid rule book.
Not a rule book, for sure.
And this particular algorithm is pretty comprehensive.
It takes us through a step-by-step process, starting with determining if the bleeding is acute or chronic.
Okay, so that's the first branch point.
And then it guides us through assessing for potential causes based on the patient's age and other clinical features.
Makes sense.
And I like how it incorporates specific recommendations for managing different conditions.
Oh, that's helpful.
From hormonal therapy to endometrial biopsy to hysteroscopy.
So it gives us concrete steps to take.
It's a really practical resource.
I like that.
And it even includes guidance on when to refer to a specialist.
Oh, that's always good to know.
Which is always helpful.
Yeah, for sure.
We don't have to be experts in everything.
Right.
But we need to know when to call in the cavalry.
Exactly.
Okay. So algorithms can be helpful tools, but we always need to use our clinical judgment and individualize our approach.
Absolutely.
Now, before we wrap up this deep dive, I wanted to touch on one more thing that came up in our sources.
Right.
The importance of patient education and shared decision-making.
That's so important.
Right? We can't just tell patients what to do.
No, definitely not.
We need to involve them in the decision-making process.
Absolutely.
And make sure they understand their options and the potential risks and benefits of each approach.
It's about respecting their autonomy.
Right. Especially with something as personal as vaginal bleeding.
Absolutely.
There are often multiple management options.
Right.
And the best choice will vary. Yeah, depending on the patients.
Depending on the individual patients.
Preferences and circumstances.
Preferences and circumstances.
Exactly.
For example, if we're discussing treatment options for heavy menstrual bleeding, we need to explain the pros and cons of hormonal therapy, non-hormonal medications, and procedural interventions. Got it.
Like endometrial ablation.
And ultimately, the decision should be made jointly by the patient and the physician.
Right. It's a partnership.
It is.
And it's also important to address
the
emotional impact of these conditions.
No, absolutely.
Vaginal bleeding can be
a
very sensitive topic.
For
women.
For many men.
And it can be associated with feelings of fear, anxiety, even shame.
All of those things.
We need to create a safe and supportive environment for our patients to discuss their concerns.
Right. They need to feel heard.
And ask questions.
And understood.
And we need to be sensitive to the fact that their emotional well-being is just as important as their physical health.
All connected.
Okay, so patient-centered care is key when managing vaginal bleeding.
It's about partnering with our patients.
It's about listening to our patients, understanding their perspectives, and working together to develop a care plan that meets their individual needs.
Couldn't have said it better myself.
All right. I think we've covered a lot of ground today.
We have. It's been a whirlwind.
We've explored
Yeah.
the causes, evaluation, and management of vaginal bleeding in adults.
It's a lot.
With a special focus
Yeah.
on the unique challenges we face in the ED setting.
For sure. Those ED cases can be tricky.
Any final thoughts you'd like to leave our listeners with?
I think the key takeaway here is that vaginal bleeding, while a common presentation can be a sign of a wide range of conditions, some of which are life-threatening.
Okay.
So we need to have that high index of suspicion.
High index of suspicion.
Ask the right questions. Do a thorough exam.
Yeah.
And use our diagnostic tests wisely.
Use them wisely.
And don't be afraid to get help when we need it.
Right. Consult with those specialists.
Exactly. Teamwork makes the dream work.
I love the teamwork makes the dream work.
Couldn't agree more.
All right, so there you have it.
There it is.
A deep dive into the multifaceted world.
The many faces.
Of vaginal bleeding.
Of vaginal bleeding.
I hope you found this episode informative.
I hope so too.
And helpful for your practice.
Yeah, it's a lot to take in.
And as always, stay curious, stay informed, and stay tuned for more deep dives.
More to come.
Into crucial medical topics. Until next time.